Okay, now this is a kind of a difficulty we run many times with the computer, and I'm always prepared to give a lecture without slides. And many times I do that also. And my job has been made very simple by Rakesh, because he's talked about various types of insulin, which I was going to talk about prandial regulation. But in my opinion, in India, the major problem is the prandial blood sugar. We are all carbocentric diet eaters. As you all aware, that our diet consists of mainly carbohydrates, and our major meal is lunch. The lunch consists of 60% carbohydrates, and that has been a traditionally and culturally Indian diet. Now we need to change that. Now you go to change that diet is going to be difficult unless you give the importance to the people about the role of prandial regulation. The biggest risk factor for typical Indian phenotype, we call him thin fat Indian, because at a BMI of 21, his waist circumference is more than 90 centimeters. All our obesity is abdominal. It's a visceral fat. It's a white fat. It is a fat without mitochondria. It is a useless fat. It is a dead weight. And we accumulate over a period of time by our eating habit, our cultural habit, and that needs to be changed. Asking them to change that is a very difficult task, both for doctors and healthcare professionals, because it is like asking them to change their culture. Now, prandial regulators are many, and you realize the greatest prandial regulator is ability to say no to the food which is served by your loving wife. She wants you to have one extra chapati, one little helping of rice, because if it's not eaten by you, God save you, because she feels that the taste is not good and you are not happy, and the feeding husbands or children or son-in-laws with a large meal has to change. So in case the people don't manage it, then there are prandial regulators, drugs, and some of them are basically, they prevent the breakdown of polysaccharides to monosaccharides, such as acarbose and voglitol, because they prevent the breaking down of polysaccharides and prevent the rapid absorption in a first hour of post-meal period. Now remember, the first hour period of prandial rise of blood sugar has to be coupled with the first phase of insulin. Now when you eat food, the signals are sent to pancreas to produce insulin, but that insulin in a normal individual is stimulated and released into portal circulation. When you take a short-acting insulin, you take it in the systemic circulation. Now to reach the insulin in the portal circulation in the liver, which is the factory of converting metabolites from glucose, is deficient. And therefore in type 2 diabetes, there is a first phase insulin which is poor, as a result of which the rise of postprandial blood sugar is a first hallmark, and that needs to be addressed by drugs, short-acting insulin analog such as Lisprp, Aspart, and a rapid-acting, ultra-short-acting insulins to bring down the postprandial blood glucose. Injection just taken before the meal, or sometimes we give it after the meal. But tablets can be mixed with the food. Many times the voglibose is taken after the meal. That doesn't serve the purpose. You have to chew the tablet, take that juice and mix it with food. Then only the absorption is delayed and it causes relief from postprandial blood sugar. Now, there are many drug formulas. They always say to control type 2 diabetes and get a TIR up to 80%, fix fasting first. And that is the role of basal insulin, very nicely explained to you by Prakash. And therefore, I feel that fix fasting first is a job of a long-acting insulin analogs to be taken before dinner. So the fasting blood glucose, which is the basis on which the day's glycemia is built. If your fasting is normal, 120 or less than 120, then the whole day's glycemic building will be under control and there won't be glycemic excursions or spurts of postprandial blood sugar. So by use of basal analog at night, you fix the fasting. And for drugs to prevent the postprandial rise, there are oral drugs and there are short-acting insulin analogs which can be given before breakfast or before lunch. Now the formulation, which is the mixtures of insulins, and there are co-formulations. Now please remember, the mixture of insulin is a short-acting and long-acting together. It's a mixture. While the co-formulation, which is a normal new variety of Rhizodec, which are the two different streams. If you see in Rudraprayag, Ganga and Jamuna flows are seen distinctly different from the sky as a black Jamuna and white Ganga. Same thing happens to you take a co-formulation, it retains its individual ability to act at each level. The short-acting arm acts at the post-breakfast and a post-lunch period, while a long-acting acts as a sustained blood sugar lowering effect and improves the action of a short-acting insulin. And therefore, co-formulation is a far superior than the mixtures, and that can be given morning or at night, depending what is the size of the meal. Normally, we tell people that you take a good breakfast, not heavy breakfast, but a good breakfast containing protein. And those people who are vegetarian can take sprouts and legumes, chana, usad, and take a small lunch. Small lunch consists of a sandwich or a soup or a salad. Evening, maybe a small snack, and a dinner also very, very little. So this pattern can definitely bring down your PP sugar. And if you ask the risk factors, the greatest risk factor, even 1 hour rise of blood sugar, even 2 or 3 occasions can cause coronary artery disease. Diabetes and coronary artery disease, Jimmy was talking so nicely, is a two faces of one coin. Now you have diabetes, 10 years later, you are bound to be on cath lab. The coronaries are getting spoiled much before the diagnosis of diabetes. And if you want to prevent the coronary artery disease, you must not allow blood sugar to go more than 160 after 1 hour and after 2 hours. 1 hour rise of blood sugar is equally a big risk factor for coronary artery disease and cardiac failure. And repeated admissions of heart failure is a cardiodiabeto-renal syndrome, which is seen more in people who cannot manage the postprandial blood glucose. Now that is very important, and that can be done by many drugs that we have available with us, many insulins which can be trained to people. Now only question is the person is working in the office. How is he going to take insulin? Well, that is a thing that you have to train them, that you have to take insulin before lunch. Now that needs a bit of training, but it is definitely beneficial. All my patients who have started taking a preprandial insulin, short-acting or ultra-short-acting, they all over a period of time change their TIR to more than 80% and had the benefit of over a period of 3 months. All of them drop the HbA1c. Now you realize today TIR is more reliable and more pathognomic than HbA1c. HbA1c can get neutralized. High and low, too many frequent fluctuation of blood sugar will tend to normalize HbA1c, while TIR will not tell you that. People who take prandial regulators, they better manage, they have a better TIR as compared to HbA1c. Now, there are many studies, there are many graphs which were there to show you how beneficial it is. Now, you must realize 10% reduction of a TIR can reduce coronary artery disease by almost 25%, while a 10% rise in HbA1c can increase complication rate by 35%. So this is the take-home message, that you have to target TIR, you have to target HbA1c, you have to target PP sugar. These are the three major risk factors in a type 2 diabetes. Friends, I am very grateful to you for tolerating my talk without slide presentation, but to the best of my ability, I tried to simplify the whole process of prandial regulation. If there are any questions, I'll be delighted to answer.
1 minute left.
Thanks again, Dr. Mahapatra and Dr. Manoria.
Thank you. Thanks a lot, sir, for your excellent speech. As we are listening since many years, you can give extempore on any topic in diabetes or any other. And we have listened your hilarious talks also in conferences. So thanks a lot for your wonderful talk.